Weaning induced pulmonary edema. I hope that you have enough brain to listen to this presentation about a very, about a very important issue, in fact. And I disclose for this presentation again that I collaborate with Pulsion Medical Systems, Cheetah, and Baxter. Is that something important? Is that an important issue? Definitely yes, because it is a quite common problem in the ICU. There are many small studies, and this study that we performed 4 years ago, where we included 81 patients who performed a lot of SBTs. And among them, and especially among the SBTs that failed, we were able to identify a weaning-induced pulmonary edema, WIPO, in not less than 60% of cases. Weaning-induced pulmonary edema is likely a common problem. It was a single-center study. Nevertheless, it is compatible with the rates reported by the other studies, ranging from 45 to 87% of cases. So you see definitely all the studies show us that it is something that is quite common. We are including patients in this prospective observational multicenter study, and we aim at including 1,000 patients. If you're interested, just write me an email to have a multicenter study. But I think that at least bear in mind the message that it is something quite common. So it is an important problem. Then there are simple questions. What are the basic mechanisms? More practically, how do we detect it and how do we treat it? Regarding the mechanisms, as you of course know, this is all due to heart-lung interactions, and we heard Ashraf Al-Tayyar about that issue, so I will go quickly through that. Basically, what we must remind is that the weaning trial, when you disconnect the patient from the ventilator or when you put the patient under low level of pressure support and PEEP, in fact, you may alter all the components of the cardiac function in the wrong direction. You may increase LV preload, you increase LV afterload, you may decrease LV contractility. All these alterations, all these impairments, of course, promoting weaning-induced cardiac dysfunction and pulmonary edema. And basically, this is due to 3 triggering mechanisms: the decrease in intrathoracic pressure due to spontaneous ventilation, the increase in pulmonary volume, especially during respiratory distress, and the adrenergic stress, which is due to the stress, to the psychological stress of respiratory failure and hypercapnia. When you decrease the intrathoracic pressure, more blood is attracted toward the thorax, and of course this increases the cardiac preload on the right and the left side. Also, the decrease in intrathoracic pressure is transmitted to the left side. It means that for the external left ventricular wall, it is more difficult to contract because there is this pressure around, external pressure, that attracts the left ventricular wall externally. It means it increases the left ventricular afterload. And it is aggravated by the hypertension that may result from hypercapnia and adrenergic stress. When you increase the pulmonary volume, you stretch the pulmonary vessels, you reduce their diameter, which increases the right ventricular afterload. And through a possible right ventricular dilation, this may reduce the LV compliance and contribute to all the dysfunction. Finally, myocardial ischemia, which may in turn decrease LV contractility, is due to the alteration of the loading conditions of the left ventricle and possibly to the decrease in PaO2. Nevertheless, myocardial ischemia during weaning-induced pulmonary edema is not very frequent, as we will see. To summarize, when you decrease the intrathoracic pressure, you may impair all the components of the left ventricular function, which may induce weaning-induced cardiac dysfunction. How do we detect that dysfunction? And it's all the very common problem. I mean, my patient has done a first SBT on today, for instance, whatever the way, for instance, on a T-tube. There is failure. I will reconnect the patient. Before tomorrow, when a next SBT will be performed, how could I know that this failure of today was due to weaning-induced cardiac dysfunction? And it is definitely an important problem, because if it is a WIPO, weaning-induced pulmonary edema, there is a treatment that may easily promote the success of the next SBT on tomorrow with diuretics, for instance. So, was that failure of today due to weaning-induced cardiac dysfunction? To answer that, of course, I must first be sure that there is no other obvious cause of weaning failure. For instance, there is obvious muscular weakness, there is obvious ongoing pneumonia. Also, I must wonder whether there is a pre-existing risk factor for WIPO. And the three risk factors for WIPO are a pre-existing COPD, a pre-existing cardiac disease, and possibly obesity. These are the risk factors that we have identified in the study I quoted at the beginning. Definitely, WIPO was more common under these instances, under these conditions, and even at multivariate analysis, independently from the other risk factors, the three ones were constantly found to be risk factors. So think about WIPO in these patients, not in a patient with normal lungs and normal heart function. There must be something in the past history of the patient that tells you there is a risk for weaning-induced pulmonary edema. And of course, and that's the most important, the third part of the diagnosis is to identify signs during the SBT that will tell me it's been due to pulmonary edema. What should we look at during that SBT? I mean, which changes during the SBT of today could indicate that there was a weaning-induced pulmonary edema? We have today 6 diagnostic tools. It's fortunate because a few years ago, the only one was the pulmonary artery catheter. And by the way, for instance, in my unit, the last condition where we decided to insert a pulmonary artery catheter for years was to detect weaning-induced pulmonary edema. Nevertheless, there are some limitations to the PAC for that purpose. If you have used a PAC already, you know that PaOP measurement might be difficult, especially in spontaneously breathing patient, and even more in case of respiratory distress, because identifying the end expiratory phase might be very difficult in such patients. Also, and perhaps most importantly, this is an invasive technique that we are not very lucky to set up just on the day when the patient will be extubated, definitely. This is why echocardiography might be interesting, because you know that through the mitral flow, the E wave, the E over E prime ratio, echocardiography may estimate the PIOP that we actually measure with a PA catheter. Nevertheless, echo is not really the solution, and I'm very sorry to say that in that particular seminar, first, echo is very difficult to perform in some patients with respiratory distress. And even more, the diagnostic accuracy is not very good. There is one study where it was shown that, look, to diagnose weaning-induced pulmonary edema, you need to evidence not only an E over A, but also an E over E prime increase. By the way, there is no reason why it should be so. And even in this way, the diagnosis was not very good. So you must measure the E over E prime before, the E over E prime during, at the end of the SBT. Is it very surprising? Not really, because again, it might be difficult to have some precise, very accurate measurements in this condition, and even more, we know that the estimation of the LV and diastolic pressure by echo is far from perfect. This E over E prime ratio is quite poorly correlated to the pulmonary artery occlusion pressure, though it is pretty much used, but the correlation is not that good, in fact. Perhaps not echo, and something much easier, which is just blood sampling. For instance, for measuring the BNP, because we know from the emergency room that BNP or NT-proBNP may detect pulmonary edema from cardiogenic origin. Is it possible to use BNP in that specific context? Yes. You could find two studies, one we performed, showing that a relative increase in BNP from before to the end of the test, of the failing test, indicate weaning-induced pulmonary edema, either with an absolute change or relative change in %. It is possible. I think it is actually possible. We know the limitations. It's likely less reliable in patients with renal failure because of false positives to BNP. And of course, it's costly. You need a measurement of BNP or NT-proBNP before the test and at the end of the test. But it requires just a blood sample, very easy to do. Hemoconcentration is likely the diagnostic technique I prefer. Why? What are we speaking about? You know that, in fact, hydrostatic pulmonary edema induces a very significant hemoconcentration, because if pulmonary edema is significant, in fact, a large amount of plasma is filtered toward the interstitium and the alveoli. By the way, for cardiogenic pulmonary edema of any cause, if you look at your patients with cardiogenic PE, with cardiogenic pulmonary edema, look, they all have a hemoconcentration, elevated plasma protein levels. And then when you treat the patient, it decreases. In fact, while you remove fluid from the patient with diuretics, hemoconcentration decreases because the water comes back in the vascular space. Is it possible to use hemoconcentration as a diagnostic tool, especially in the context of weaning-induced pulmonary edema? Yes, if you look at that study we performed years ago, where we showed that patients with weaning-induced pulmonary edema had a significant increase in the plasma protein concentration and an increase by more than 6% compared to the value before was quite good to diagnose WIPO. This is an example. Take that patient at 8:38 in the morning, the plasma protein is 58. The patient performs the SBT and fails at the SBT. You sample blood at the end of the SBT and you see that plasma protein concentration increased to 75. What else could create a so rapid and a so strong increase in plasma protein concentration? And if you sample blood after reconnecting the patient, you could see that it goes back, it decreases back to its initial value. Again, I think it's very interesting. You can use, by the way, hematocrit as well. It's not costly, it's very easy, no specific examination for that, so it's the diagnostic technique I prefer. What about lung water? Because of course, lung edema increases the lung water. Is the detection of lung water that we use with transpulmonary thermodilution with a PICO system, does it enable the detection of pulmonary edema in that specific context? Because it's a very rapid increase in lung water. This is what we tested in that study, and we showed that actually in patients with weaning-induced pulmonary edema, if we measured the lung water, it had significantly increased only in patients with weaning-induced pulmonary edema. So you perform thermodilution before the test, at the end of the failing test, and an increase by more than 14% in that study was quite good for diagnosing weaning-induced pulmonary edema. Nevertheless, be careful. It doesn't mean that we should use PICO just for that purpose. It means that it is not reasonable to use that invasive device just on that day when the patients will be extubated. Okay? But if it's still in place on the day when you extubate the patient, think about performing thermodilution at the end of the test. But there is another way, we heard that from the previous talk, to assess lung water, which is lung ultrasound. And here, this might be an interesting solution. In that study we performed with Daniel Lichtenstein, you see that we performed the lung assessment with ultrasound before the SBT and at the end of the SBT. And of course, we looked for new B lines, an increase in B lines. Of course, some of these patients, because they had been ventilated for days, had already B lines. So we wanted to show that an increase in the B lines, in the number of B lines, could indicate WIPO. And we counted the number of B lines in all the 4 quadrants of the anterior chest wall. We showed that if the number of B lines increases by 6 or more, we could say there was weaning-induced pulmonary edema. So you measure the number of B lines in on the 4 quadrants of the chest wall before, and when the test is failing, if the total number increases by more than 6, it may tell you that your patient has that very frequent pulmonary edema from cardiac origin due to weaning. Finally, how do we deal with that problem? How do we treat it? Unfortunately, we have very few studies to tell us how we should do in practice. But it's very important, because if my treatment is efficient, it means that my patient will be extubated tomorrow, very rapidly. And an efficient treatment may or should decrease the duration of ventilation. I need a very active, a very efficient treatment. What should it be? There are 5 options, I think. It's always described that you should do angioplasty in patients with ischemia during weaning. Nevertheless, myocardial ischemia is not very common during SBT. For instance, in that study by the team of Armand de Sapp, it was shown that weaning failure plus ischemia was present in only 4% of the patients, so it's not very common. But of course, if it is present on the EKG, for instance, you should perhaps do angioplasty to your patient. Dobutamine. Many colleagues like dobutamine to avoid pulmonary edema in that circumstance, but I don't. It's illogical because since ischemia is not common, the decrease in contractility is rarely the cause of weaning-induced pulmonary edema. And we know all the risks of dobutamine administration, especially in that context of adrenergic stress, the risk of cardiac arrhythmias, etc. This is why we never use dobutamine to avoid that. You may use nitrates just on the day, on tomorrow, just on the day when you perform the new SBT, and this might be interesting for reducing the level of hypertension. So you set the dose continuously, adapt the dose of nitrates to avoid hypertension. ACE inhibitors, perhaps. And of course, the main treatment is based on fluid removal, diuretics or ultrafiltration. But the question is always, which volume should I remove from my patient today in order to prepare the SBT of tomorrow? And here, I would like to finish on that important point. To know the level of ultrafiltration or fluid removal you need, look at preload responsiveness. In that study, we made the hypothesis that patients with cardiac dysfunction are more likely to be preload independent. If they are preload independent, it means that their heart is not able to cope with the impairment of the loading created by weaning. Otherwise, on the other side, preload dependent patients have a normal heart, it's a normal condition, and they can easily cope with that change in loading conditions. And so for that, we performed before the SBT. Before the SBT, we performed a passive leg raising just to test whether the patient was preload responsive before the SBT. And we showed that actually the passive leg raising test before the next SBT could predict pretty well that the next SBT could lead to pulmonary edema again. And you see the area under the bracket. If the PLR test was positive, if the patient was preload responsive, it was very unlikely that WEPO should occur on the next day. Of course, we do not use passive leg raising to predict what's going to happen during the next SBT. We don't need any prediction, we do the test. But perhaps it means that we should remove fluid until the patient becomes positive to passive leg raising. And this is supported by what we showed in that study I quote from the beginning. Look, in patients in whom we gave diuretics. In some of them, this induced no change. The passive leg raising test was negative and remained negative. They did not become preload dependent. Almost all the patients experienced a new SBT. Why? If diuretics had changed the patient from fluid unresponsiveness to fluid responsiveness to preload responsiveness, a new SBT was very unlikely. This suggests that, and otherwise in the patients with no diuretics and no change in the passive leg raising test, a new SBT was very likely. So it means that when diuretics are used to treat the patient, likely if the patient becomes preload responsive, WIPO is less likely. So perhaps it means that we should go on with fluid removal until the passive leg raising test becomes positive. It remains to be directly demonstrated, but it's likely something we should look at. To conclude, my dear friends and colleagues, we have seen that these are complex mechanisms. We have seen that these complex mechanisms are responsible for something which is quite common. We have seen that we have some numerous reliable and lowly invasive diagnostic methods to diagnose WIPO. And finally, we have seen that it is possible to individualize the treatment and to choose options depending on the phenotype of the patient. And I insist again on the degree of preload responsiveness. And with this, I thank you very much for your attention for this last lecture.
Fantastic. Thanks very much, Prof. Xavier. And here comes a question, which is, I think it's like legitimate now to say, if we correlate the extravascular lung water in the term of assessment of diastolic dysfunction by EE prime plus the lung ultrasound to increase the pre-test probability, will that make any difference in the term of accuracy in our test?
Very good question. It must be demonstrated, but I agree that it is possible. If you combine E over A prime, which is not very good when it's taken, when it's only considered, and if you add the lung ultrasound, perhaps the diagnostic accuracy is improved. The problem you will have is that lung ultrasound alone is already very good, as you saw in the study we did. The drawback of lung ultrasound in that context, I see that in practice in my patients, is that it's a bit cumbersome. You know, you have to count the number of P lines here, 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 and then do that again. So, but in any way, this might be helpful. So the problem you will have if you do that study will be to show that it can be better than something which is already very good, which is just typical simple lung ultrasound.
Perfect. Okay, I'll look if we have any more questions here from attendees. Okay, so I think because we are summing up together and all questions are okay for all the speakers, a question here to Dr. Ashraf Al-Tayyar. You have mentioned using TP trial. Could that lead to pulmonary stress during spontaneous breathing trial? Which method do you recommend for a spontaneous breathing trial? I'm sure he's asking about TP trial versus low PEEP or low pressure support.
Very good question. And again, as Xavier just mentioned, if you have a high risk group of patients, COPD, previous cardiac disease, or obesity patients, then maybe it's better to go with a low pressure support, 5 to 8 pressure support in inspiratory pressure. Better than you go with the TPs for predicting if patient will tolerate this or not. The evidence is so far showing that the TPs trial is carrying a lot of risk, and it's more stressful for the cardiac function, especially in those high-risk group of patients. So what's recommended so far is to go with a low pressure inspiratory pressure support of 5 to 8, above PEEP, of course.
And I totally agree with Ashraf Al-Tayyar. The TPS trial is the most challenging for the heart. And it's been, by the way, clearly demonstrated by a study comparing the two modes of SBT. Definitely. And so the only question is that sensitive enough if you do a low pressure, a low pressure support and low PEEP test, is that sensitive enough for detecting all the cases of weaning-induced pulmonary edema? We are doing a study to compare that, but I totally agree that for the heart, the most challenging test is a TP trial, and it might be a reason for preferring the low pressure support, low PEEP test.
One comment to Dr. Professor Xavier. Thank you a lot for the great lectures. The late guidelines for diastolic dysfunction, American Heart Association and European Cardio Imaging Association, talk about grade 2 and grade 3 diastolic dysfunction. There is increased left atrial pressure. Could be the end point of using diuretics for the patient with weaning-induced pulmonary edema. Could be, and would be easy to be, the end point will be grade 1 diastolic dysfunction. I will give diuretic to the patient to reach to the grade 1 diastolic dysfunction. That means there is no increase in left atrial pressure. And this would be safe if I liberate the patient from mechanical ventilation. Could be the end point of using diuretics. This is number one. Questions. Questions two, I feel that you see assessing fluid responsiveness on mechanical ventilation with assessing VTI is difficult and very tricky and need a lot of experience. If we go outside the heart by looking to major vessel like carotid artery, and it's very easy to access the carotid artery by a linear probe and very easy to get a proper angle for duplex. And I will assess the systolic, peak systolic variability with mechanical ventilation. And there is a study done in this regard, and the cutoff value was for 14%, and do well compared to other studies. Why I'm talking that? Because really it will be very easy for a lot of intensivists to do that, because checking VTI and rechecking after it's very tricky really. But carotid Doppler is accessible, and already we are relying on pulse pressure variation in the radial artery. I'm not talking about radial artery, peripheral artery, and the pressure change. I'm talking about central artery and volume change. Would you mind to do a trial about that? Because it will help a lot of intensivists, because it will be easy for fluid responsiveness state.
Thank you. Two very good questions. Regarding the first one, about adaptation of diuretics to the right atrial pressure. In theory, you're right. It's not been demonstrated, and you know, sometimes there is a step between the theory and the practice, but it's a very interesting hypothesis, and it should be tested in a way. Regarding your second point, I agree with you. I mean that if there is no A line, it might be much easier to look at the carotid flow and its variations than looking at VTI. Why? Because I know real life. In many cases, the respiratory variation of the VTI is due only to the fact that the blood flow goes up and down compared to the echo beam. It's not due to preload responsiveness. It's just because the guy who does the echo does not know how to follow the blood flow, which is very difficult. So I agree with you. There are not enough studies. I also agree with you on that, because it's quite easy to assess, you're right, but there are not enough studies about that. It might be the carotid one, but also the femoral one, even though it is a bit further compared to the heart. But it needs to be investigated. The problem is that it will still have the same limitations as PPV and SPV, many conditions where it's not possible to assess them. But as you have seen, The relative changes in PPV might also be interesting during passive leg raising, during a VT challenge, etc. So I take your point, and I agree that it should be tested in further studies. Very good idea.
Last questions, please. We are talking a lot about increase in VTI, LVO, TVTI. But this VTI is going to vital and non-vital organ. The stroke volume, which we are relying on and talking a lot about since years, it's going to the lower limb, upper limb, and at the same time, it's going to the vital organs. Why not to look for the VTI of the vital organ? I am not saying all vital organ, but at least the most vulnerable and the first vital organ to be affected by hyperperfusion, which is the kidney. Why not to rely? Because I am sure, yeah, this will help a lot if we go during shock to the just the color flow to the kidney and doing pulsed wave Doppler on the renal blood flow and follow this VTI of renal blood flow, because this really will give a very clear message and important message, because I am targeting my target, which is a vital organ. But looking to the VTI as a whole, maybe there is muscle trauma and vasodilatation making a lot of blood going to the muscle. Well, I'm not sure this VTI is going to my target. I am doing that for years. I used to do the vital organ pulsed wave Doppler in any patient with shock. I do transcranial, hepatic flow, and renal flow. And I find it is very, very useful in management, especially the kidney, because really brain suffer late. Like in the early organ to be suffered is the kidney. And it's very easy to assess the kidney by curvilinear flow. And I don't know what's that, but we need studies about that. I have hundreds of cases and hundreds of images about that, yeah. And
okay, really sorry, we are a bit behind time here, so I will give the mic to Prof. Xavier to
rapidly.
Rapidly.
Again, you have very good ideas. If you have such cases, you must publish them, because it's a good idea. There will always be the problem that it is the body that regulates the relative part of the vital and non-vital organs. So you have no way to play on that, to interact with this distribution. But in theory, I agree. Then whether it is useful in practice should be demonstrated. If you have such cases, really, you should show that.
I might just add in 30 seconds quickly a comment on that. Not the assessing the flow to the organs in terms of the VTI, as you said, Dr. Shibl, but there is a validation, a study which was published a few months ago on the venous congestion score. And it looked into what are you mentioning, looking at the renal vasculature, the renal arterial and venous flow by Doppler, the hepatic venous flow, and the portal venous flow. And they actually analyzed a score which looks into the degrees of systemic venous congestion. And they found this has been done on a big number of patients, I think probably about 200 patients after cardiac surgery. And there was a good correlation with mortality in those patients tested. So I think that could be linked to what you're saying. That could potentially be used as part of this splanchnic organ assessment, as part of the whole body ultrasound, if we may.
Okay, so that's perfect. So I think this will be updated next year in the next conference. So we'll take it from then. Dr. Ashraf Al-Tayyar, please take the mic. We want to conclude and finish the conference because we are 13 minutes behind our time, and I can see some people already got really tired.